Good evening, everyone. My name is Ashok Vaid. I'm a medical oncologist working at Medanta Medicity Hospital. A very warm welcome to everyone present here and all those who are present online. The format for the program this evening is that we have in-person meeting here in Delhi, and we have 4 more centers who are joining online from Bhubaneswar. The program directors are Dr. Ghanshyam Biswas from Bhubaneswar, Bangalore, Dr. Amit Ratan, Nagpur, Dr. Anand Pathak, Chandigarh, Dr. Chitresh Agarwal. A very warm welcome to all my colleagues from all across the country and everyone who has joined in for this very interesting and a scientific feast this evening dwelling on the topic of hepatocellular carcinoma. I don't need to give you the numbers. 40,000 patients per year in India, and it's not the numbers which is the issue. We have far more cases as far as lung, breast, oral cavity, and so on and so forth, but it's the access to treatment. And also, this indeed is a malignancy which is a typical multidisciplinary treatment approach. A diseased organ harboring a malignancy poses its own challenges. You need the medical oncologist for sure, you need the surgeons, you need the interventional radiologists, you need radiation oncologists, you need the hepatologists at the core of everything. And therefore, that is the challenge and that is the opportunity for the patient to get a better medical care. Ladies and gentlemen, I have the privilege of introducing our international speaker, Professor Arndt Vogel. He is the Professor of Medicine, University of Toronto. He is the Longo Family Chair in Liver Cancer Research, University Health Network and University of Toronto. He is the clinician scientist at Toronto General Hospital, Princess Margaret Cancer Center. All of us know that center. A lot of pioneering work has been done there. He is a prominent figure in the field of oncology and in the GI oncology. His involvement in the GI oncology research space actually underscores his commitment to advancing the field of oncology and his dedication to improving the care and treatment options available for patients with gastrointestinal cancers. If I have to read his CV, I would be spending a lot of time here, but in short, he sits on the expert committees of various international bodies like ESMO, ASCO, and the others. He's been a member of ESMO for formulating the guidelines and being a member of the steering committee, and has provided key recommendations for managing biliary tract cancers and hepatocellular carcinoma. Without further ado, I take this opportunity to invite Professor Vogel for his talk on the subject of the challenges as far as the hepatocellular carcinoma is concerned, and this would be an experience sharing durvalumab plus GemCis as the new standard of care in advanced BTC. Professor Vogel.
Yeah, thank you very much for inviting me. It's a great pleasure to discuss with you the recent advancement we have made in the treatment of cholangiocarcinoma. And as you know, it was a long journey, and we really have not made a lot of progress in recent years. So before I start, just to briefly highlight, when we talk about BTC, we are talking about different tumor types, I would say. We have intrahepatic cholangiocarcinoma, extrahepatic, and gallbladder. And I think in terms of treatment, we have not really separated them too much in the past. We know that the incidence is rising, specifically for intrahepatic cholangiocarcinoma. And today, we would strongly recommend to perform broad molecular sequencing, because we have in this tumor type a lot of druggable alteration. And here is an example for intrahepatic cholangiocarcinoma, where we can find in up to 50% of cases genetic alterations for which we have already drugs available. And therefore, we need to be more clear on whether we are talking about an intrahepatic or extrahepatic cholangiocarcinoma or gallbladder cancer. This is the most recent update from the ESMO guideline that we have published end of last year. We go into all the details of early, intermediate, and advanced stage. We would recommend adjuvant treatment as of today with capecitabine. Broad molecular sequencing, as said before, is strongly recommended before we start systemic therapies. And then, as for patients with locally advanced or advanced HCC, we would recommend GemCis chemotherapy, but either durvalumab or pembrolizumab, both with a 1A recommendation. In second line, FOLFOX or irinotecan-based therapies, and then, as mentioned before, all the druggable alterations that can be found and should be tested for in BTC. In terms of chemotherapy, we really have not made much progress. We have the ABC02 study with GemCis is better than Gem, and we have the data from the ABC06 study that FOLFOX is better than best supportive care. When we add more chemotherapy, it does not necessarily mean that we add more efficacy. Many of these trials were negative. Actually, only the Japanese study with S1 was positive, and the SWOG study was just published today as full paper in JCO. There was no benefit for the addition of nab-paclitaxel to GemCis chemotherapy, both for progression-free survival and overall survival. So more chemo does not really help us in this tumor type. Therefore, how can we proceed? And there were some data that some of the BTCs are inflamed tumors and that the addition of immunotherapy may be helpful. Immunotherapy alone has no place in BTC. One of the first, or the first study that was published was the TOPAZ study, and I think you are all very familiar with the design. We have GemCis durva chemotherapy backbone given for 6 months or 8 cycles, and then patients were switched to either placebo or durvalumab maintenance therapy. The benefit is shown here. Curves are separating late, as we usually see it with immunotherapies, but then over time we do see the benefit from the addition of the checkpoint inhibitor, and we have more patients with long-term survival. And I think in the past we were not able to really report 2 and 3 years survival data, and you can see the number of patients that do achieve this landmark are increased when we add a checkpoint inhibitor. This is also an interesting analysis, I think, from the updated survival data, and here we looked at the outcome according to response, and I think it's always important to highlight that achieving a response has really prognostic implications. So patients that are not responding usually have a poor survival, both in the control and the experimental arm. It looks better in those that have stable disease here in the middle, and you can see the curves are starting to separate very early, and there's a benefit for the addition of the checkpoint inhibitor. And then when we look at patients with a complete or partial response, interestingly, curves are running together for quite a time, but then they are widely separating, and I think this is the benefit of the immunotherapy, that we do see these long-term survival benefits, which needs to be appreciated when we discuss these data. One question, of course, is, are there any subgroups of patients that should not be treated? And this is a very busy slide, but I think we need to have and look at all these information to really understand. And it's really difficult to draw conclusions based on these post hoc analyses because the numbers are getting small. We have different points to consider. First, intrahepatic versus extrahepatic versus gallbladder, and then we have the different countries and continents. Yeah? And if we break this down, you can see that almost in all settings, in all countries, in all disease types, we do see the benefit in favor of the experimental arm. So based on these data, I think we cannot really assume that any subgroup would not benefit. And personally, I would also include the gallbladder cancer here, because you can think maybe the hazard ratio in the group is only around 1, but when you look closer, you can see that in North America and Europe, we do see the benefit again for the checkpoint inhibitor. And I think the most concerning problem was here the gallbladder cancers in South America, which really did not derive any benefit. Yeah. So looking back and looking at these numbers, I think and this is what I do in my clinical practice, I treat all cholangiocarcinoma patients, including gallbladder, with durvalumab, and I think this is what we recommend in most guidelines as of today. Of course, we would like to have a biomarker to identify the responders, PD-L1 was a very obvious biomarker, and here the TAP score was used, basically, which looks at the area that is positive for PD-L1 in a certain tumor area. And you can see that with more PD-L1 expression, we do not really have more efficacy. So PD-L1 is not a good biomarker, and I think most likely because of the heterogeneity of this tumor. So we cannot use PD-L1 to select patients. At the moment, we would recommend it basically to all patients, and if we do that, we of course need to consider toxicity. And if you look at the numbers here, and this is a very detailed, crowded slide, but I think the main take-home message here is that with the addition of durvalumab, we do not add toxicity. The numbers for most of these side effects are very similar between the experimental and control arm. Of course, we do have more patients that develop immune-related side effects in the durvalumab arm, but the other side effects are clearly driven by the chemotherapy, and they are very similar in both arms. When we see data from clinical trials, one question is, of course, always, can these data be basically reproduced in real-world setting? And these are data from Italy, real-world data for TOPAZ from their first patient, and you can see it really nicely recapitulates the data from the phase 3 study. PFS and overall survival is very much in line with what has been reported from the TOPAZ study, also overall response rate and disease control rate. In terms of toxicity, now real new safety signals, so I think these data confirm the efficacy and safety of durvalumab in BTC. Of course, we also need to mention the second positive phase 3 study, which I also think is important because it gives additional weight to the efficacy of immunotherapy in BTC. And you can see here, pembrolizumab was used as checkpoint inhibitor, same chemotherapy backbone with gemcis, but here patients were allowed to continue with gemcitabine over these 6 months, 8 cycles of induction therapy. In terms of efficacy, very similar picture, very similar hazard ratio, slightly better in the TOPAZ study than here. So I think we have a clear confirmation that adding a checkpoint inhibitor improves overall survival. Of course, we would like to see more, and we of course would like to identify the responders, but this is work for the future. And just coming to the end very briefly, again highlighting the differences between intrahepatic and extrahepatic cholangiocarcinoma. So on the left side, you see the genetic alterations of intrahepatic cholangiocarcinoma, and on the right side for extrahepatic. And you can see this is clearly dominated with P53, KRAS, and CDKN2A deletion. But we also do see a lot of druggable, potentially druggable alterations in extrahepatic cholangiocarcinoma, and I think it will be really important to sequence all of these patients to identify patients that may benefit from targeted therapies. And just to give you some examples of those drugs that are already available as of today, as you can see, for many of these targets, we have multiple drugs and combinations that can be used, specifically for HER2, FGFR, BRAF, and also KRAS. We have now more drugs and combinations available, and there are a couple of studies ongoing which really evaluate new and additional targets in BTC. And when we take all of this together, we really end up with more than 50% of patients that could be candidates for targeted therapies. But again, it depends, of course, also, as mentioned before, availability and also reimbursement, which has to be considered. But we do have seen some approvals, not only chemotherapy, but also the approvals for the targeted therapies. Pemigatinib and fudibatinib have been approved for FGFR2 fusions, ivosidenib for IDH1 mutant cholangiocarcinoma, and the BRAF combinations. And this has also been implicated, of course, or included into the ESMO guideline that we have updated end of last year. And this is here the screenshot on the targeted therapies. We are really making progress, and we have more targets which are now also officially recommended by the international and national guidelines. So in which direction are we heading? I think one interesting study is a study from AstraZeneca, the ADAMITE study, which looks at a bispecific antibody targeting PD-L1 and TIGIT. And I think that's a very interesting approach to improve the efficacy of immunotherapy in BTC. Interesting also to see that really AstraZeneca jumped here into a phase 3 study with not too many early data, so we have to wait and see. The study is recruiting at the moment, and we will hopefully get some updates in the next years to come. One thing that is also interesting and to consider is the combination of local and systemic therapies as we do it in HCC. And one example is the IMU-Y study, which we are conducting in Germany, where we combine STRIDE with Y90. The study is still recruiting, but I hope that we will finish recruitment later this year. And there are some other studies which also look at the combinations of local and systemic therapy. And I think for these liver-limited patients, we should clearly look for the addition of local therapies. I prefer always induction with chemotherapy first. And with this, I'm looking forward to our discussion and maybe some cases to be presented. Thank you.
That was an amazing presentation and a lot of learning out of that. And looking at the gene signatures and the futuristic therapies. And what is unfolding is that, again, this is not one disease. Probably this is going to be even a larger, it's like a big basket of diseases, in one. And I think we could take some questions or comments or quickly from, please. Can somebody pass on a mic?
My question is basically regarding maintenance strategies in biliary tract cancer. So for patients who do not afford or are not eligible for an immune-related immune checkpoint inhibitor, what is your strategy for maintenance, something like capecitabine or gemcitabine? What is?
Yeah, that's a very good question. So I think, before TOPAZ and Keynote, I was always struggling whether I should stop treatment after 6 months or whether I should continue. And to be honest, I was never really convinced that we have sufficient evidence to stop treatment, right? In colon cancer, we had trials which looked at the de-escalation of treatment, but we never had these trials in BTC, and it was just because of our colleagues in the UK said, okay, we do it only for 6 months and then we have too much toxicity, but this is not evidence, right? So actually before TOPAZ and Keynote, I continued with treatment and I did not stop if the treatment was somewhat well tolerated, and I only stopped when the patients really developed side effects. I personally do not believe in maintenance therapy with gemcitabine. I think for me, gemcitabine is really an extremely weak drug, and I'm not really sure whether it's the effort worth to continue, and you have also the cumulative toxicity. So my strategy was, Durva or Pembro maintenance is what I'm doing now. I did never really switch to capecitabine as we do it in colon cancer, that we do this switch maintenance therapy. So I either continued, maybe sometimes at a lower dose level, or I really had a break and then continued after, for example, 2 or 3 months. But then I re-challenged the patients, if possible, before progression.
Thank you so much. And are we taking questions from other centers as well? Are there any questions? Please go ahead. Could somebody text it, or and then we can in the interest of time, we can take that question later. I think, let me thank Dr. Vogel for this wonderful presentation, and then we'll have you once again yes, for the next presentation. And let's move on. The next case discussion on the BTC case, I hand over the proceedings to Dr. Amit Rautan from Bangalore. Amit, are you there? Excuse me. Over to you, Amit. if there is a difficulty in connecting with Bangalore, I think could we meantime connect Bhubaneswar otherwise? No, there's no audio.
Am I audible?
Yeah, yes, now we can hear you.
Yeah. Thank you, sir. So today is the first case we'll be discussing. This is a 71-year-old female with nil comorbidities. She presented with the complaints of loose stools and pain abdomen. This was in September 2023. And her ultrasound abdomen showed lesion in the fundus of gallbladder. It was infiltrating the adjacent liver. Her CT abdomen showed again the same gallbladder lesion. It was measuring up to of size 5.3 into 3.3 centimeter, same infiltrating the liver, and there were also multiple enlarged portal, portocaval and peripancreatic lymph nodes. And her tumor markers were CA 19.9 was 10.6, CEA was 2.8, LDH was 254 and AFP was 2.3. And biopsy from the gallbladder lesion showed adenocarcinoma, and her IHC markers was suggestive of gallbladder cancer, and also she was HER2 negative. The score was 1+, and MMR was proficient. So the further imaging, her PET CT scan, it was done in October. It showed metabolically active wall thickening involving the gallbladder, infiltrating the adjacent liver parenchyma, and multiple enlarged periportal, portocaval and same peripancreatic lymph node. Basically, it was a clinical T3, N2 and M1 disease because of the non-regional lymph node. It was coming to stage 4B. Her tumor NGS showed ATR mutations, TMB was low and MSI was stable. No targetable mutations were present. She presented to Manipal Hospital in October for further management. This case was discussed in MDT and it was not operable and upfront, it was metastatic. So she was decided to start on anterior chemoimmunotherapy. She was started on gemcitabine, cisplatin and durvalumab first line. She completed the 4th cycle of this by December 23. And her PET scan after 4 cycles showed partial response. The wall thickening of the mass involving the body and fundus of the gallbladder that showed reduction in thickness and activity. The reduction in thickness and activity, enhancement, extent of infiltration into the adjacent liver, that is segment 4B, 5, 8, everything had come down, and the lymph nodes were largely stable in size, and metabolic activity had also come down. So she completed 6th cycle of chemoimmunotherapy by February 24. Again, MDT discussion was done and the decision was taken to proceed with surgery considering her good response. So after surgery, it was done in March 24. The histopathology showed YPT3N0, LVI was present and PNI was present. She completed 2 more cycles, that is total 8 cycles of chemoimmunotherapy by June 2024. Later, considering various factors, she was started on maintenance capecitabine. We had to stop durvalumab. So she is continuing on maintenance therapy till now, and her latest PET scan was done in Jan 2025. It was showing no evidence of disease anywhere, and till now she continues to be on the same treatment.
Thank you, Dr. Soumya. So I think we have a panel here with us, and yeah, we have Dr. Poonam Patil, we have Dr. Abhay Kumar, we have Dr. Srivari, and we have Dr. Vishwajit Pai. So welcome all of you. We have a quick 15 minutes. Let's discuss the just discuss a little bit about this kind of a case. Uh, uh, Dr. Poonam, this kind of a patient who comes, sometimes we see patients with some metastasis which is low volume. Do you think in gallbladder we can start saying, do we sometimes oligometastatic gallbladder cancers?
Yes, certainly. Local therapy does have a role even in metastatic gallbladder cancers, especially in oligometastatic disease. Even if there is solitary liver metastasis, we sometimes give radiation to that area and treat other areas with a curative intent. Definitely, oligometastatic disease has got local.
So low volume metastasis, sometimes we get tempted to be a little bit more proactive. Dr. Abhay, do you, if you had a disease which is going to these kind of non-regional metastasis, do you think this was a right way, or should we have actually just given chemo and then seen what to do, adding durvalumab, staying this metastatic disease with those kind of nodes? We eventually discussed a lot between pros and cons of doing just chemo, seeing what happens, or just putting chemo durva. What would you do in this situation?
Definitely, we will begin with the chemo but considering only lymph node metastasis, no peritoneal metastasis, still we have option of cure if it is we are able to remove the all lymph. Because what is the best chance is that we are able to give him some prolonged duration of disease. So we'll do the same kind of discuss in time discuss with the provide subsequently based upon the kind of risk. If there is a progression is there, then there is no point. Chemosensitive, most probably this is I think right way.
Yeah, I think we always say if there's just a node there with gallbladder and it's liver invasion, we definitely talk to our surgeons, and surgery is the best way forward. The only patient in this patient, the nodes were extensive and they were all going into the peripancreatic region, so it kind of got labeled as non-regional lymph node metastasis, and the way the invasion was, it was not operable at that time. So that's the reason why this thought was given.
But she was lucky to have N0 status ultimately.
Yes, correct. Actually, so it may have been that the nodes were really not involved. It's very difficult to say now. So ideally, yes, if she was ready, we should have given the opportunity of doing a laparoscopic and evaluation, doing a biopsy and checking out those nodes and then taking up the next steps. Dr. Shivali, what biomarker testing are you doing in this kind of a gallbladder carcinoma when they come to you? What are the biomarkers you always test for?
So like done in this case, we are definitely going ahead with MSI, PDL1, as well as we are doing a flex gene panel, sir, in our institute, wherein we can pick 10 genes, whichever we want, and they do. So definitely HER2, we are doing like HER2, FGFR, and IDH, whatever is available, we are trying to go ahead with an NGS, definitely.
Yeah, I think gallbladder now has become very, very dominant for us for testing. What we do in our institute is do a HER2 IHC and an MR IHC very quickly, because that hardly takes us 1 or 2 days to get the report, and then the rest goes for an NGS. We're not doing too much of PDL1, really not seen much relevance to PDL1 gallbladder cancers. So that's, but definitely we are testing all our gallbladder and cholangiocarcinomas with this kind of a panel. Dr. Vishwajit, there was this, Dr. Vogel showed us that trial, that triplet versus doublet doesn't help, and it's best to give a doublet. We did see some small segment from that trial saying that in gallbladder carcinomas, triplet was a little better than a doublet, though the cholangiosis it did not help, and of course the OS did not help at all, it was not better at all. Do you get tempted to try a triplet in any situation?
Very tempting, because in my observation, if a patient progresses, about 50% of them are actually unfit for a second line therapy. They might present with jaundice, which doesn't come down with any drainage procedure. So given the fact that the patient is young, maybe not in this patient who was 71-year-old, maybe we've seen younger patients, 40s and 50s, who are generally fit. Maybe we can try the triplet in them, because I still believe that the first line is always the best in BTCs.
Right. So yeah, I was actually saying, can I put these questions, a little bit of some questions to Dr. Vogel? Dr. Vogel, your thoughts on if we have a gallbladder cancer, not the cholangiosis, the gallbladders, taking the subgroup out and trying triplet versus doublet. And secondly, your thoughts on this kind of a patient who has metastasis to the nodes, we downstage and we operate. Is that a decision we should take or not?
Yeah, I think it's a very good question, and I think we are always tempted to do that. And I agree. So I think the phase 2 study for Gemcis nab-paclitaxel was quite encouraging, right? I mean, for locally advanced, and this was also in the SWOG trial, that in the locally advanced and gallbladder subgroups, the response rate was higher, right? Numerically higher, and there was a trend to a better outcome. And again, I mean, when we discussed the TOPAZ data in the gallbladder cancer with all the doubts on subgroup and post hoc analyses, I personally think it's if we have somebody we really want to downstage for resection, I would consider doing the triplet. And actually in Toronto, we have decided to start a neoadjuvant study where we use Gemcis nab-paclitaxel plus the new bispecific antibody from AstraZeneca. So we are actually trying to combine basically the doublet chemo, we add nab-paclitaxel and the checkpoint inhibitor, because I mean, we don't really know, but I think in these, even if the SWOG trial is negative, and we have to admit that in the SWOG trial, I mean, it's a negative trial no matter what, but in the control arm, the median overall survival was quite long, right? Longer than we have seen in other phase 3 studies. So I think there is at least a signal, and I see it a little bit like FLOT in gastric cancer, yeah? So there could be a role for peri-interventional downsizing, downstaging setting to bring more patients to surgery. And I think it's not yet completely over.
Yeah. Thank you, Dr. Vogel. Yeah, I think we do use triplets in certain situations and in practice, and especially gallbladder cancers, we are still doing it in practice for certain patients. Dr. Poonam, if this patient was HER2 positive, do your thoughts change in terms of management?
Yeah, that's also a very good question.
I would add trastuzumab-based therapy for this patient.
Yeah, so this is very, so when we talk about HER2 positive, different people have different, even we talk of always adding trastuzumab to chemotherapy. Dr. Vogel, I think you still do immunotherapy plus chemo when you see patients with HER2 positive first line?
No, we have, I mean, luckily we have a couple of clinical trials, right, which look at the combination, and I think we are all a little bit driven by the keynote data in gastric cancer to really use targeted therapy plus checkpoint plus chemotherapy. And I still think we should do it within clinical trials, but of course we are tempted to do it also outside of clinical trials. I mean, we have the AstraZeneca trial, right, a 3-arm study which looks at different combinations also with trastuzumab deruxtecan. We have from Jazz Pharma the trial. We have an IIT in Germany where we also do Gemcis, trastuzumab, and pembrolizumab. So I think there are a couple of trials, and there's clearly a rationale to proceed. But again, I'm not sure whether we are already at a point to should recommend it outside of clinical trials, even though I understand it's very tempting, of course.
Yeah, there was some data from an Indian publication which said that trastuzumab chemo at least is better than chemo alone, and that's why all of us in India use trastuzumab chemo in certain situations in such patients. But
yeah.
But I agree. It would be lovely to see the stomach-like data where you're talking of IO, chemo, trastuzumab as a combination as first line.
Right. Amit, this is Dr. This is Dr. Amit. Hello.
Abhay,
Amit,
your thought on let's just quickly look at cell-free tumor DNA.
So,
do you do ctDNA in
Amit, I'm
this kind of
Amit, sorry to interject here. I think in the interest of time, we might have to sort of, wrap up soon. We are,
right, sir.
Yeah.
So this was the last question, sir. Done.
Sure,
yes,
please.
So Abhay, you can take this.
No, sir, ctDNA not in this situation.
Really, no ctDNA.
I think we should do so because in such case was completely responded, and then in adjuvant only I think the bean is being given.
Yeah.
Maybe ctDNA will help us when we should start our IO and.
Right. No, I think the future would be MRD testing in such group of patients, and I think with this, it's an exciting time ahead for biliary cancers. And with this, I would like to thank everyone in the panel. Thank you very much, sir. Thank you very much.
And Amit, are Dr. Shekhar Patil and Dr. Vijay Agrawal there? If they have a comment to offer?
No, sir.
They are
no,
not
sir,
here. Okay. Okay. In that case, thank you so much, Amit, for that wonderful moderation and a very interesting case. In fact, something which happens in the clinic on a day-to-day basis with us, all of us. So that would be a very interesting takeaway from this meeting. Thank you so much once again. And let's move on. And I invite Dr. Ghanshyam Biswas for the next case presentation. It's a BTC case. Ghanshyam, can you hear me? We can't hear you, Ghanshyam. Still not. Ghanshyam, we can't hear you. Could somebody?
We are starting the case, sir.
Yeah,
Yes.
yeah. Okay, thank you so much.
So, good evening, sir. So, the case is about a 63-year-old male with a history of diabetes mellitus complaining of non-radiating right hypochondriac pain and also intermittent vomiting. So initially he has been evaluated outside and they have given from the ultrasound point of view, they have given that it is a acalculous cholecystitis. Then the CT scan done and also in the CT scan there is a finding that that the gallbladder is partially distended with mild thickening up to 5 to 6 mm with a zone of non-enhancing fluid density to pericholecystic collection and there is a solitary 7 mm lymph node and they also stick to the point that it is an acalculous acute acalculous cholecystitis. So the surgeon first saw the patient and they go ahead with laparoscopic cholecystectomy and the post probably during the time of doing surgery they are suspicious about that it could be a malignancy, so they went ahead to go and try to do the radical surgery as much as possible. So the post histopathological evaluation, it is infiltrating adenocarcinoma, moderate differentiated, site is EB, T is 3 to 3 centimeter maximum dimension, perimuscular connective tissue is involved, neck margin involved, LVI PNA is positive, and one lymph node taken it out, that is T2A and one disease. So that was the finding. So we discussed later on in the MDT and then finalized, we try to go for the radical cholecystomy rather than doing in laparoscopy. We try to open it and do the liver resection margin and also trying to do the lymph node dissection also. So this was the second surgery and done very successively within 1 month. And they have done the wedge resections of the liver with scalloped triangle dissection along with the other extended lymph node and the dissection and also the epigastric portal tissue, the port site is also been dissected. The cystic duct margin is negative for malignancy, the liver weight is negative for malignancy, the port site was negative, all system margin negative, and 17 lymph node taken out and nothing is positive. So he was on follow-up and post, and after that we have also done the PET-CT, and the PET-CT was there is no evidence of disease, and then we plan to give 6 cycles of gemcitabine along with cisplatin because of the locally advanced disease. And if you see the incidentally detected gallbladder operated, then radical resected, and enough data, little bit data is there from the MD Anderson group and also from the TMS. So we plan to start gemcitabine along with cisplatin. So 6 cycle we have given and completed in September 2023, and post September 2020 completion, and we have tried to do the PET-CT and there is no evidence of the disease. So but surprisingly, and after a 3 month of follow-up period, the C19.9 started rising, and the CT scan showing there is a lesion in the gallbladder along with the peritoneum aspect also. So we try to figure it out whether it is a what is the extent of the disease, and then we have successfully done an PET-CT just after 3 months, and it is showing the internal development of the metabolically active the hypodense surface peritoneal deposit in close relation to segment 4 and 7 of the liver, with internal development of the nodular deposit in the subhepatic space and also and probably in the lung, there is some lesion in the lung. Try to go ahead with a biopsy to document, and it was metastatic adenocarcinoma. The HER2 testing has been done, it was negative. Then then we try to figure it out, what should we do? Whether the platinum free interval was 3 to 4 months, whether we should give Folfox or we should give Gemox. So we try to figure it out. Probably the platinum sensitiveness was less than 6 months, so that's the reason we thought to go for the Folfiri. If you into a paper which is I think 2021 it has been published, second line Folfox versus Folfiri in in metastatic VTC, and they found the Folfox equal to Folfiri. We opt for Folfiri because the platinum interval was less. So we started Folfiri, then later on we add Durvalumab after the NGS report. So this was the NGS report from the TMS where there is no actionable mutation find, MSA status could not be done. There is SNBD was not there, SNB was not detected, fusion was not detected, nothing good found, and the patient took a second opinion to do the NGS from the Garden 360, and they told the TME value is high, it is 12.27, MSI was not detected, and they found that MLH1, there is though the percentage of the DNA amplification was 0.2% and EGFR mutant also 0.4%. So as these are the rare and unknown mutation in this regard, and because TMB high, and we went to the literature and saw that TMB high, though may not be predictive, but may not be a prognostic, but may be a predictive marker to use Durvalumab, so we add Durvalumab later on. So patient completed a 6th cycle of Folfiri along with Durvalumab, then you have done the re-evaluation, and there is a partial response, liver lesion has reduced in size. Then we continue to give Durvalumab, and till I think completely 15 cycles of Durvalumab is done, has already been done, and currently the recent PET-CT you shown that there is mixed response, low volume mixed response, decrease in size somewhere, and probably there is somewhere there's increase in size also. Increase in number of metabolically active lymph node, probably 4 number in the subhepatic collection, but they are very subcentimetric, around 0.6 to 0.7. So we also till today we are planning to continue. Thank you very much, and this is the recent city finding.
So thank you, Dr. Chinmay. So Dr. Chinmay Pani is a senior medical oncologist from Bhubaneswar Utkal Hospital, and we belong to a state where probably gallbladder cancer is one of the highest in the country, besides head and neck cancer. And the patient journey which Dr. Chinmay showed is not very uncommon. So incidental finding, and then we pick up a malignancy. So my first question to Dr. Sri Gopal will be, this is a 63-year-old lady who undergoes a surgery for a simple cholecystectomy and then found out a T3 lesion, right? So T3 lesion, so here it was T2, but so T3 lesion, and then there was no evidence of disease on the scan, the subsequent scan. Now you counsel the patient for a completion surgery, and so 5 out of 10 patients may not agree for that. So what is the next thing you are going to do for this patient?
So, sir, I will first go for the imaging.
So imaging is done, there is no evidence of disease.
Yeah, imaging was no evidence of disease. I'll counsel for the repeat surgery. And in practice, most of our patients they agree. But in fact, if they are not agreed, then definitely we have to go for chemotherapy. But after adequately explaining them the chances of recurrence, that they are not going for a completion surgery, then they are not doing a adequate local treatment, so there is a high chance of failure. We'll counsel them the pro and cons. Then after consent only we'll go for chemotherapy, and same time I will do the molecular marker also if possible.
So can I go back to Dr. Vogel? So we belong to a place so where this situation is very common. So 30-40% patients won't agree for a second surgery, which is a radical surgery. So any thoughts on putting this patient who is T3 disease above a scan negative? So would you advocate, besides surgery, would you advocate any local radiation and IVFU, some sort of systemic therapy and local therapy in terms of radiation?
Yeah, I think that's a very good question, and I think we are always struggling a little bit whether we should add radiation to these patients or not. And I personally am not really convinced that radiation will really help us. And I think the meta-analyses that have been published suggest that there may be a benefit for R1 resected patients, but maybe a detrimental effect for R0 resected patients. So in Toronto and in Hanover, we stopped and we did not offer any more any adjuvant chemoradiotherapy, and if at all we do also adjuvant treatment. I think it's I mean I understand the intention to use GEM-CIS, but honestly we don't have data for that as well, right? And the STEM study with GEM-CIS in extrahepatic was negative, so as long as we do not have the data from the ACTICA study, I'm a little bit hesitant to use GEM-CIS, even though I do understand that we are all not happy with capecitabine alone. But in most of my cases, I still use capecitabine as a systemic therapy in the adjuvant setting.
Right. So that was my second question, and you answered that. So probably I would have put the patient on capecitabine because a more positive disease. I know that this patient is going to fail after some time, and then probably we have a robust orthopas-1. So, so Dr. Bogan, so we are talking about a platinum sensitivity like many other cancers, so maybe a lung cancers, maybe ovarian cancers, so many other cancers who talk about platinum sensitivity. So do we say that categorize that this patient progressed 3 months after the platinum? So should we talk about a platinum resistance in a BTCs?
I mean, this is also a very good question. And I mean, based on the ABC06 study, we started this discussion, what defines platinum resistance? And I think in contrast to other tumor types, in BTC, we do not really have good data for that, right? And we know it's a very aggressive tumor, which is rapidly progressing if we do not apply therapy. So I'm not 100% sure to which extent we can apply these terms of sensitive and resistance and whether we can base it on the duration of treatment. I mean, the ABC06 study suggests that we can use FOLFOX after GEM-CIS, right? And despite progression. So, I mean, once we have started GEM-CIS in the adjuvant setting, I mean, 3 months is very short for recurrence. And I also understand that it's tempting to use another chemotherapy backbone. If it recurrence after 6 months or later, I probably would re-challenge with GEM-CIS, but I understand if we have early recurrence and these patients have a very poor prognosis, I would also tempted to switch chemo.
Right. So coming back to Dr. Srigopal, so he's a medical oncologist from SCG Cancer Center, Qatar. So Dr. Srigopal, now, so this patient has progressed with a standard platinum background, so within 3 months. So now is your protocol. So Dr. Chinmay has used irinotecan based with durvalumab, but we don't have a data for that. So these are costly drugs. So what is your take? So what would have been your choice? And the second is because we know that durvalumab is given 3 weekly and FOLFIRI will be 2 weekly. So how you are going to plan your treatment, if at all?
That way, sir, I will be choosing between Capox or Capiri. So of GEM-CIS progression, post GEM-CIS progression, I usually go for Capox. Then I keep the Capiri regimen next line. So here, if patient is not having very much comorbidity for like high risk for developing peripheral neuropathy and all, then still Capox I'll be going for. But if someone is giving Capiri also, sir is given, that's an option also I can consider. But I will prefer Capox in the first line if a patient is not having high risk for developing neuropathy with auxiliary platinum.
So 63-year male diabetic patient, 6 cycles means 12 doses of already cisplatin. So this patient will have at least a grade 2 neuropathy, must
right.
have a grade 2.
Yes, so there I will go for Capiri plus durvalumab.
Right. So, and then probably you can sequence 3 weekly both of them, otherwise
yes,
it will be difficult. So what are the biomarkers reversals you are going to do? So with the available Topaz 1, so are you going to do, because MSI is seen in only 0.5%, and though there was a different form of PDL1 that was TAP, which was used unlike TPS and CPS. So what is your take on that?
Here for molecular markers, I will be choosing the HER2, then FGFR, IDH1 and 2, then other MSI, obviously IHC I will be going for. TMB, I will see in selected patients where finance is not a constant in our Indian practice. If it is not a constant, I will go for TMB also, same time, the CGP panel. Otherwise, selected panel, I will go for this HER2, then our FGFR2, IDH1, 2.
Ghanshyam, sorry, I'm interjecting here. I think
last.
Yeah, please. Okay,
So
let's go.
Yeah, Dr. Bogle, so there's a question for you, last question. So this patient IC HER2 was negative. So now there are recent papers in gastric cancer where in spite of a HER2 negative on an IC, so if you put them on a fish, so there is a 15 to 20% increment in positivity of a HER2 news. So any thoughts on that? The last question, sir.
So I would be hesitant, to be honest, and when we look at the data that have been published, both from the Destiny study, but also the study from South Korea, it really looks like that those that do not have a high expression of HER2 do really not derive a lot of benefit, right? I mean, the 3+, I mean, they really had a benefit, but in 2+, there were hardly any responses. So only 2+ or even negative plus fish, I would be really hesitant to use it. It depends. I mean, if you can afford it, I mean, I would try it, but I would not expect that there would be much benefit.
Dr. Vogel, since we are going to be wrapping up the BTC, very quick comment from your side. You showed very elegantly showed the gene signature for the intrahepatic versus the extrahepatic. Now, if you look at the gene signature for gallbladder and extrahepatic, do they look similar, or do they look as an entity different from the intrahepatic?
I think the main difference is that we see the FGFR2 fusions and the IDH1 mutations mainly in the intrahepatics, right? And then we have a lot of p53 KRAS in the extrahepatic and also gallbladder. I don't think that we have anything else very specific for gallbladder compared to extrahepatic cholangiocarcinoma. I think the frequency of some of these alterations may differ a little bit, but I think in principle they are very similar.
Thank you so much. Ghanshyam, thank you so much for that wonderful presentation and wonderful moderation, and lot of learning out of that. I think the issue of gemcis versus capecitabine, as already pointed out by Dr. Vogel, capecitabine continues to be the preferred treatment as an adjuvant. Am I right? Thank you so much. So, I think we'll have to. Let's switch gears and move to the next segment, which is the HCC. And I have the honor of inviting Dr. Vogel once again to talk about IO as the new SOC in the management of unresectable HCC. Over to you.
Like a brief summary of the data, and I think most of you are very familiar with the data. Some are more recently published, but I think it's very exciting to see that we have made so much progress in recent years. And the ESMO guideline needs to be urgently updated, and actually the update has almost been accepted by Annals of Oncology, and hopefully we will get the publication in the next weeks. What you can see is that we have a lot of options for systemic therapies. We can apply sequential therapy, which is good, but which also requires that we make decisions to decide what is our best first-line treatment. And of course, in earlier stage, we have really a lot of local therapies we can apply, and for all liver limited, I think it's essential to really have a tumor board discussion on what is the best treatment. We have, for many of these treatment modalities, now head-to-head comparison, but we know that all of them are effective. Of course, the only curative approach would be liver transplant, which also cures the chronic liver disease in many cases, and resection. But also the ablation, SBRT, intra-arterial therapies can be highly effective, and in some patients we can achieve at least a tumor-free stage for quite a while. And when we think about systemic therapies, it's very obvious that we have seen many trials. I mean, in the sorafenib area 10 years ago, we discussed all these negative trials that have been published after that. And then with the REFLECT study in 2018, I think the first positive phase 3 study in the first-line setting, and then we did observe all these positive studies that have been published afterwards. And with that, we have clearly made progress. So we do have now a longer median overall survival than in the old days. And I think it's also important to point out that it's not only because we have better combinations, but also because we can apply sequential therapy. So if you look, for example, at the median overall for sorafenib, it was for many years only 11 months when we had no second-line treatment. And then with the introduction of second-line treatment, we did observe a longer median overall survival for these patients in the control arm from 11 to 15 months, and actually the same also for lenvatinib, where we have seen a median overall survival of almost 20 months in the last 2 phase 3 studies, compared to the 13 months which we have seen in the REFLECT study. And when we look at the IO combinations, we have now our benchmark of 24 months, and this is the best we can achieve at the moment in unselected patients with HCC. And just briefly looking at the trials, I mean, the IMREV 150 study was the first positive study, as you know. Atezobev significantly improved response rate up to 30%, PFS and overall survival, and the side effect profile was clearly in favor of the IO combination, and with that it was approved and recommended by all guidelines. But we have also seen very interesting data for the combination of 2 checkpoints, and the first study was the Himalaya study, 3-arm study, one of the largest studies that have been published so far, and also here we observed a higher response rate compared to sorafenib, and in terms of overall survival, non-inferiority for durvalumab was shown and superiority for STRIDE, which means the addition of a single high dose of tremelimumab to durvalumab. In terms of safety, again, the safety profile was clearly in favor of the experimental arm. When we add tremelimumab, we do not only increase efficacy, but also toxicity, of course, so there were more immune-related side effects, and more patients require steroids, so from 10% with durva to 20% with STRIDE. But again, when we look at the efficacy endpoint plus the safety profile, it was, and we today would recommend STRIDE over sorafenib in the first-line setting. And the latest study that has been published is the Checkmate 90W study with Nivo-Ipi. So here more CTLA-4 was used, and actually in this study we have observed the highest response rate of 36%, and also the overall survival was clearly improved compared to here mainly lenvatinib to almost 24 months. However, the survival benefit and the higher response rate comes at a price, because here we really observed more side effects, more immune-related side effects, of course. Treatment had to be stopped in 20% of cases because of toxicity, and 30% of patients required high-dose steroids, and 12 patients actually died due to treatment-related side effects, and most of these patients died because of liver-related complications. So it is an effective treatment, but it comes at the price of toxicity, and we really need to see how this will work out in clinical practice when we have patients that are more frail or have a more impaired liver function compared to these clinical trial patients. And I think for these IO combinations, it's really important that we should not only look at the median overall survival, because curves are separating late, and here in the with STRIDE you can see in the beginning the curves are very close together, but then with the long-term follow-up, and this is something that has to be highlighted, we can now report long-term survival data with these IO-based combinations. You can see 4, 5, 6 year survival for these patients, and the number of patients with long-term survival are clearly higher in the IO combination compared to the sorafenib or TKI treated patients, up to 20% after 6 months, which has not been shown ever before. And unfortunately for the IMREF 150 study, we do not have any long-term follow-up data. One additional point that was highlighted in the updated survival analysis from STRIDE was the impact of disease control. And of course, we always would like to achieve a partial or complete response. But what you can see here, also disease control is important. So on the right side, you can see patients that are not responding have a poor prognosis, no matter how they are treated. However, when we look at the patients with disease control, which also includes patients with disease stabilization, of course, we do see a clear separation of the curves, which means that disease control with immunotherapy is more meaningful and longer lasting compared to what we achieve with sorafenib or lenvatinib. Again, the tail of the curve is here important, and when we look at the 5-year survival data, they are clearly enriched in the IO combination arm. So having said that, this is where we are today. We have a lot of combinations and we need to make decisions now. We can either go for TKIs or we can use the IO-based combinations, and here we have to decide, should we go for combinations or monotherapy? And here durvalumab or tislelizumab would be options with positive trials. And if you go for the combinations, we need to decide whether we want to add VEGF component or whether we use a pure IO combinations. And of course, decision-making can be challenging, and I think, having these options, it's important to also look very closely to the patient. So what are the comorbidities and what are potential contraindications? And it's very clear that with the addition of bevacizumab, we increase the bleeding risk, not only from varices, of course, and we have also the VEGF-related toxicity, so we have more hypertension. So cardiovascular comorbidities is also something that we may want to consider. And last but not least, underlying autoimmune diseases may also be a contraindication for checkpoint inhibitors. In addition to the efficacy, we also, of course, need to look to toxicity, and you can see with all the treatment regimens, we do see quite a high number of side effects. But the side effect profile is clearly different. And what I would like to highlight here is first the grade 5 treatment-related adverse events, which were clearly enriched in the nivo-epi study. And in terms of steroid use, which was also enriched in the nivo-epi arm. So we have 10% for IMBRAVE and for durvalumab monotherapy, 20% for STRIDE, and you can see here 30% for nivo-epi. So also something we need to consider when we make our first-line decisions. And when we then look more closely into the side effect profile, and I don't want to go into all the details, of course, just highlighting what I have said before in terms of the cardiovascular profile, here with bevacizumab, we do see in quite a number of patients hypertension as a side effect, which was clearly lower when we use STRIDE without bevacizumab. Again, side effect profile should be something we should consider when we make our decisions in the first-line setting. Bleeding, I have mentioned it before, with BEV we add a bleeding risk no matter what, right? Even in these highly selected patients in the IMBRAVE study that have received endoscopy before starting treatment, we observed 7% bleeding events, which was clearly lower with the other combinations. So bleeding is something we need to keep in mind, and we need to screen our patients accordingly to rule out at least varices. Which other point can we consider? And one question we have discussed a lot in the past is, what about the underlying immune disease? And there were some data in mice suggesting that mice with fatty livers do not respond to checkpoint inhibitors. However, this has not been recapitulated in our clinical trials, and you can see on the right-hand side the summary of the trials that have been published, and you can see the benefit is always in favor of the immunotherapy, and if at all we could argue that there may be a higher benefit in those with an underlying hepatitis B infection. But on the left-hand side, you can see the data for STRIDE from the Himalaya study. There's clearly a benefit for the non-viral group. So I think the underlying liver disease should not have a significant impact on our decision-making. The last point I would like to make is liver function. And I think it's really important that we consider liver function for our decision-making. Not only that outcome is clearly affected by liver dysfunction, and we know that patients with more advanced liver cirrhosis have a poor prognosis. But also when we look at the efficacy of the immunotherapy, there are differences. Here for STRIDE, we do see a similar efficacy of patients with IB1 and IB2. So patients with a more preserved liver function compared to those with a more impaired liver function. No difference. I mean, it's prognostic. Overall survival is shorter, but the efficacy of STRIDE is similar. Interestingly, in the IMBREV study, we also saw this prognostic impact, but we also observed that in the IB grade 2 patient, there was no benefit for atezobev compared to sorafenib. And the benefit of this trial was really purely driven by the IB1 cohort. And I think this is something you should consider when you make your decisions, that atezobev is really good for IB1 patients with really almost no liver cirrhosis. And here we do see a high efficacy with a hazard ratio of 0.5. However, in those patients with a more impaired liver function, as we see it in clinical practice, the benefit is clearly far less pronounced. I'm not saying that it's not effective, but it's the benefit compared to sorafenib is less obvious. So I think it's really important when we discuss our patients in the tumor board is that we are very clear on where are we starting, what is our intent, and what do we expect from the treatment. Yeah, so in patients that are resectable upfront, I think there's probably no need for any systemic therapies. At least we do not have any convincing data. Of course, we can think about neoadjuvant or bridging to improve outcome and to avoid progression, but this depends on the setting. Per se, we do not really have a strong indication to use systemic therapy in this setting if we can go right away to surgery or transplant. Then we have these patients with borderline resectable, borderline transplantable tumor. And here our aim is really downstaging, downsizing in order to offer curative treatment. And here I think it's really interesting to consider also the recent data from LEAP and CARIS to combine local and EMERALD, to combine local and systemic therapies to achieve really a shrinkage of the tumor and bring these patients to surgery. And last but not least, we have those patients that are really with very advanced but still liver-limited disease, but where our intent is mainly to improve overall survival and to offer palliative treatment. Having said that, we also know that we can achieve complete responses and deep partial remissions today, so there's still the window or the opportunity of this curative conversion. And I think for these patients, it's really important to discuss them in the tumor board if they have a response, whether we can offer them any potential curative treatment. So even for those patients, I think it's worthwhile when we see that they're responding to rediscuss them in the tumor board. Yeah. And here, the data I wanted to show you for the combination in intermediate stage, liver limited. I think it's a very exciting field because we have now the EMERALD data, higher response rate with the addition of durva and bevacizumab, and also progression-free survival is clearly improved. No overall survival data published yet, but the data have been confirmed, if you like, with the LEAP study. Also very high response rate with a combination of TACE plus, in this case, Venva-Pembro, improvement of progression-free survival, but no overall survival benefit. And I think that's something we need to consider because it's probably nothing we need to offer all of our patients, a combination of local and systemic. However, when you look at these response rates, I think it's really worthwhile to consider this approach in those patients I have mentioned before, these intermediate borderline resectable patients, to get a response and then offer additional surgery or transplant. So today we have options which is really good, but which also requires decision making. Yeah? And I think we need to consider all these parameters that have been highlighted here. Of course, patient factors, comorbidities, as I've mentioned before, bleeding risk, cardiovascular, performance status, age, tumor factors in terms of liver-limited, extrahepatic disease, vascular infiltration, liver factors, and specifically liver function, very important for prognosis, of course, but I have shown you also the efficacy of the immunotherapy may depend on the grade of liver dysfunction, and for atezobev, no real benefit in IB2 cohort. And then we need to discuss our treatment aims. So are we in this early setting, do we want to delay progression to bridge for transplant, for example? Do we need to downstage to resection or transplant? Or are we in this palliative setting with the option of maybe curative conversion in at least a subgroup of patients? And with this, I think we need to make our decisions and discuss them in the multidisciplinary tumor board to offer really the best treatment. Thank you.
Thank you, Dr. Vogel. That was a wonderful presentation. I think a very complex disease where we are dealing with many challenges. And I have a very quick question before we pass on the proceedings to Aditya. Do you use immunotherapy at all? You had one comment that it should not be used routinely.
This is outdated. This needs to be
post-transplant.
Yeah, we use it before and after transplant, to be honest, right? So we have now good data that we can use it before transplant, that we can really downsize, downstage patients. There should be a washout period of around 4 to 12 weeks before we proceed with transplant. And after transplant, I have also used it as last line, really last line treatment, right? We started with Lenva, Cabo, Zora, Rego, whatever is possible, Folfox, yeah, local treatment. And if everything has been used and this patient is still progressing and fit, then I do mono immunotherapy. So I have treated patients with checkpoint inhibitors after transplant.
How much would be the rejection rate?
I think from the data, it's around 30%.
30%.
Yeah.
Thank you so much. With that, I think let's move on, and I invite Aditya Sareen to proceed with the next presentation and a case discussion on HCC. Over to you, Aditya.
Thank you so much, and I thank the organizers for having me here. And obviously, we have this wonderful panel with us. Can I have Dr. Arndt Vogel over here on the stage, please? Dr. Ajay Gupta, Indraprastha Polo. Welcome. Doc Saab is a medical oncologist over there. Dr. Anshul Gupta, Max Vishali. क्या ना snacks बाद में खा लेगा बुलाओ तो सही in the meantime, Dr. Vinod Arora, who's a hepatologist at ILBS. And so my slides are going to be pretty much interesting because I'll be pausing in between and I'll be discussing the case with my amazing panelist. So can I have my slides on? And I think Anshul, Amresh, give him coffee quickly. Where is he? I'm waiting for Anshul, otherwise I'll start. Bad sir, मेरे को कहेंगे कि इधर time खत्म हो गया.
I think in the interest of time, let's move on. Lot more agenda to transact.
Yeah. So, okay. So this is a story. I think you can't see from here. Can you guys see? No, you can't. Organizers. So you have two problems. My panelist can't see the slides and your liver is on the left side. You need to change the liver to the right side. Over there, it's the reflection, mirror image. Oh yeah. So I think sir, it's better that they come in front. Otherwise they will not be able to, see it. So, with past conference which I had to do so many impromptu decision making. So that is what doing conferences does to you. So, okay, so this is a 35-year-old young female who was diagnosed with hepatitis B along with the CLD in 2016, started on tablet tenofovir. There was no abdominal pain, no loss of appetite, no abnormal altered bowel habits. So basically she's a 35-year-old young girl, hepatitis B related CLD was there, and since 2016, so that makes it approximately 9 years back. Now during surveillance in 2019, ultrasound whole abdomen was done. So mind it, all the treatment history which I am going to give, patient has not yet come to me. There is one point when patient presents to me, it is all the past history till now. So she was found to have a liver as well in the segment 2, and on further evaluation, she was diagnosed to have HCC of 1 into 1.5 centimeter in segment 2 with elevated, hardly little bit of AFP elevation, and she was referred to other hospital for further management. Then, CT abdomen was done, which was a triple phase. Again, it showed a cirrhotic liver with portal hypertension with lesion characteristic with HCC. And multiple other, MRI did give us, Lyrides 3 lesion in the, and Lyrides 2 in the bilateral lobes. HBV DNA, because she has been continuously taking tenofovir, she was absolutely well. And on endoscopy, she was found to have small high-risk esophageal varices. What they did outside was the laparoscopic resection of the HCC, and it did go wonderful. And the final comment was the patient is having HCC of segment 2, HBV-related CLD with portal hypertension, compensated, child PUG-A, MELD, NAT12. So this was the operative finding. They were able to see liver is grossly cirrhotic. And again, R0 resection was done and patient was discharged from on the tablet tenofovir. So Dr. Vogel, if you have any patient with you on surveillance, does they come to you first or do they go to medical oncologist or do they go to your hepatologist? What's the sequence at Princess Margaret?
So the patients without cancer are treated in the hepatology department, right? We have the TCLD, the Toronto Center for Chronic Liver Diseases, and we do follow up a lot of patients with viral hepatitis and non-viral hepatitis, and all the surveillance is done in our center.
So, Dr. Vinod, what's your practice over there at ILBS? Everybody comes to you, or some med-onco also gets and they refer it back to you?
Usually we get the, primarily we get the patient and then we refer to the med-onc.
Med-onco. And obviously, considering this case, Dr. Arora, still the question is to you.
Yeah.
Are you comfortable with the approach they have used in a 2-centimeter lesion in a young female with hepatitis B and CLD, or you would go anything different?
Maybe microwave ablation or radiofrequency ablation would have also suffice the purpose.
So yeah, that's why I want to know which of these three, just a second, let me pull out my pointer. I think it's not visible here.
If it would have been non-cirrhotic, then it would have been a different story altogether, but she had varices.
So how do you feel when one says resection, one says transplant, or one says locoregional, therapy? Transplant, obviously we all agree, we have our own criteria, but how do you choose between A and C, locoregional therapies and resection? What is that figure which you are looking in a patient where you will be comfortable sending this patient to for a resection vis-a-vis to an intervention radiology?
Maybe if the patient was having no varices, platelet would have been normal, and non-cirrhotic SCC would have been an ideal candidate for resection.
But they did go and they did remove the tumor in this patient.
The patient did well.
Dr. Ajay, any thoughts? Or are you in sync with the current discussion that we are having right now?
I'm in sync with the current decision. Resection, patients may not prefer resection, they might prefer non-invasive modalities or even alcohol ablation.
And Indian patients are one of those patients, jo bhi ho jaye, doc sab surgery mat karana, uske in short you can get everything done. So we have a fear, and even our community has fear of undergoing, surgeries. So yeah, I think at the right moment, if this patient would have presented, number one in our list would have been to go for a loco-regional kind of a therapy, and then followed by that, if the patient wants, a better thing, I think resection. Dr. Vogel, do we have any head-to-head trial versus resection in small liver nodules vis-a-vis the loco-regional therapies?
I think we do have a couple of real-world data sets and retrospective analyses looking at the efficacy of both treatment, and I think overall, it's very close race, right? And it's always depending on who looks at the data. I think resection is an option, ablation is an option, and also SBRT for the small tumors. And if you are in Chicago, you probably would also get Y90, right?
Right.
As a third
and in India as well, you can get Y90.
Yeah. So I think it depends a little bit on, patient preference, location of the tumor, and what is available in the
And if I were to say, radiation, ablation versus arterial directed therapies, your take 1, 2, 3. How would you sequence it?
For a tumor of 1.5 centimeter, I think ablation.
Yeah, let's make it 2 centimeter.
Yeah, even 2. I think ablation is fair, but also SBRT. The data are suggesting that it's maybe even better than ablation, right? So SBRT or ablation, I think, would be less invasive, and then, but I mean, resection, if it's laparoscopic and in the periphery, I mean.
Okay. So obviously, if you don't have those therapies available at your center, resection is an option, but you have those locally ablative therapy, I think you better go and do these ablative therapies. So we have Anshul with us. Dr. Anshul, welcome. He's a medical oncologist at Max Vishali. And now coming on to the next slide. So, I am Brave 050. Dr. Anshul, your thoughts about the trial? The adjuvant setting where patients have been given atezo-bev after the patient had undergone, curative ablation. Any idea about the trial?
So, I mean, so far there's no hands-on data to suggest.
Oh, this is the data?
No, but...
I will show you the data as well. But what's your thought? Have you ever used in any high-risk patient this combination as an adjuvant?
So no, but to tell you the truth, that I get a lot of patients from the transplant unit.
Yeah.
And what they do instead is that post-transplant, due to some reason, I find that most of the patients are on lenvatinib.
Agreed.
But not
you need to educate them a lot more. That's the problem.
This regimen I have not used personally.
Fair
I have
enough.
not seen anybody
And
use it.
I will tell you what NCCN guidelines still recommends. Obviously, I know Dr. Vogel is keen to come in, but I will pause you for a moment. They say that adjuvant therapy with atezo and bev may be considered in patients with high risk of recurrence, size more than 5 centimeter, more than 3 centimeter tumor, or a microvascular histology, on a case base, because they read this first interim analysis at 12 months, which showed a high risk of recurrence after resection and a higher rate of recurrence after 12 months compared to the active surveillance, although OS was not established. But very recently, this interim analysis was updated in this year, last year's Barcelona, and you can just see how the lines are overlapping. So to the tunes that if we were to see the RFS, atezo-bev is 33.2 months and active surveillance is 36 months. So NCCN is supposed to take this recommendation back. But the problem with atezo, it does every time like this. You see in breast cancer, you have this. They get you FDA approval fast and they take it back. You see in bladder, you give the FDA approval, accelerated approval, they take it back. And now the same is going to happen in the HCC. This is this slide and this EE format is from the NCCN. You see the EE over here? So they say, till today, the guidelines, they are yet to be updated. If this case were to us and we had any of these high-risk situations, we might have been tempted to give this combination atezo-bev, I think 2-3 months back. But after this Barcelona, I think it just makes no sense. Because there is no RFS benefit, there is no OS benefit here. So I am brave. Dr. Gupta, Dr. Ajay, any thoughts?
So can you just show me the graphs?
Sure.
So the previous one?
Yeah.
So this atezo-bev was given for 17 months or 12 months? 12 months. 12
so 17 doses.
So just show me,
Yeah.
So for 1 year, if you look, the graphs are separating out.
Absolutely.
So we don't know whether if they had continued until disease progression like most IO trials do, whether it would have shown a
But all the IO trials are like this. You give it only for 1 year, then you stop. Because then we assume they are going to have an immune regulatory effect post the completion. Everybody thinks that the immune system is now prime.
So it may not be working that way, but...
So your thought is that if we were to continue this for 2 years or 3 years, we would have...
disease progression, then we don't know what...
Agreed.
Yeah.
Hypothetically speaking, it's still possible, yeah. Dr. Anshul, any thoughts on the plot?
I'd not use it.
Fair. Okay. So again, 5 years down the lane, 2024. Now this is a story of 9 years, how this patient is doing. Obviously, she was well and still being followed up there on primary center. And now this time, she had complaints of jaundice, myalgia, pain in abdomen, and considering the previous history, she underwent the CCT whole abdomen, which showed a 10 centimeter lesion in the left lobe of the liver, along with the arterial enhancement, delayed washout, with multiple other lesions. Let me just quickly complete it, otherwise I know our time will go. So free fluid in the peritoneal cavity, some omentomesenteric stenting, and prominent nodes in the periaortic, para-aortic or mesenteric nodes. So the final diagnosis was a fairly well-defined mass lesion involving the left lobe of the liver with hepatic metastasis in the background of the hepatic parenchymal changes with minimal ascites, abdominal nodes, splenomegaly. Mind it, this was just a CECT triple phase. She underwent biopsy outside and she did get a moderately differentiated hepatocellular carcinoma. Then the PET scan was done. Even a PET scan showed multiple lung lesions, bilateral lung, 1.1 centimeter, and this is a very recent case. So, if I were to just conclude, so there were main primary left lobe lesion, multiple lesions in both the lobes, multiple lung lesions, multiple lesions in the abdomen. So you can just see how the disease was appearing, how her liver tumor of 10.5 centimeter was, we were able to capture it on the PET scan. Generally, we don't see that much amount of avidity in a HCC on a PET, but somehow this lady did have, and I think there is no question about it. So, with this all reports, with this all history, then she presented to us, and because she presented to me after the PET scan in January this year, and she had further deterioration in the past 7 days. Her abdomen became tense, she developed persistent vomiting, she became technically PS4, unable to go to the washroom, she technically became bedbound. And she was advised to go home on tablet lenvatinib, which she even took for 1 week, and to just continue best supportive care at home. On evaluation when they came, she was having a bilirubin of 6.6, AFP of 1,75,000, a PIVCA of 25,000. So, Dr. Arora, your thoughts? What should be the child PUG status, or
child C?
Yeah, and BCLC?
BCLC D, best supportive care. The only hope she has. What is the DNA level? Was she compliant with the heavy treatment?
So DNA level is negative.
There's no reactivation.
Yeah, no reactivation.
Okay, I don't think you can do anything.
Agreed.
Much.
Fair enough. So obviously, I hope I am correct with this when I am saying I have a patient of metastatic multifocal HCC with jaundice, gross ascites, and non-regional disease. So obviously it's a metastatic disease with lung and multiple non-regional nodes. Hepatitis B positive with CLD, with child PUG score I was having 12. So that is 12 by 15, that became child PUG C, and a BCLC-D. Dr. Vogel, what would you do next? You have options: treatment, no treatment, role of palliative care, whatever you say, I'll go with that.
Yeah, so I think it's important to really understand. I mean, first of all, it's really sad that she did not have more follow-up and surveillance, and that the tumor was diagnosed so late. Then I think it's, and I didn't capture it so fast. I mean, the question is, why do we have this poor liver function, right? And I think it's always worthwhile to consider it may not only be the underlying liver disease, but also the high tumor burden, right?
Agreed.
So, and we need to be careful to which extent the bilirubin and all these TRIPUC parameters are really due to the liver cirrhosis, or to which extent they are due to...
But how to untangle that wire, it's technically impossible.
Yeah, it is impossible.
You can see OT is 411 and PT is 54 only.
Yeah. I mean, she obviously has very advanced liver cirrhosis. I'm just saying this is something to consider and keep in mind. So how much preserved liver function the patient has.
Yeah.
And then the question is, I mean, in those cases, obviously she has also pain, right? I mean, did she have pain? So I would consider radiation as an option for palliative treatment, right?
She was having persistent vomiting, for which she became technically bedbound, because she was puking, and because of vomiting she developed intercostal muscular pain. Yeah. So much so, I had to give her a full dose of morphine.
Yeah. So I think palliative radiation is something that should always be discussed. Yeah. I think she's not fit enough for any systemic therapy or lenvatinib with TRIPUC. I would not offer.
So, Vad sir, now you're...
Aditya, I think we'll have to, in the interest of time,
in 2 minutes.
2 more cases.
Yeah, that's it. It will be done in 2 minutes, don't worry. So obviously...
So palliative care, my vote
your thought would go palliative care.
But,
Dr. Gupta?
But is there a pressure on the biliary tract? Why she has jaundice? I think that's a pertinent point.
So, she is having...
still remains unanswered.
She is having multicentric disease in the liver. The tumor, one main tumor is of 10 centimeters. Then she is having multiple more small tumor beads in bilateral lobes.
So, palliative care.
Palliative care, agreed. Dr. Gupta, any?
Yeah, palliative care.
Dr. Anshul?
I would agree with that.
Right. And the same thought was with the husband. Will she make it? Even if she makes it, is she going to have a troubled quality of life? And will take the patient home as patient is having advanced stage cancer, and better to be amongst the family members.
I have a more troubling question here.
Sure, sir.
Who was following up this patient?
Let me not go into that, sir.
No, but still, was it a loss to follow type of a situation?
I think let's discuss it beyond completion of this. Otherwise, this will take me to the another direction.
Yeah, sure. I think let's wrap up
Yes.
and move on.
So obviously, I am in sync with the NCC, and they say, do best supportive care. But then again, when patient comes to me, and even if there is a little bit of hope, after discussing with the family members who were keen on taking the treatment, and I took a high-risk consent and shifted the patient to MICU, took a different and a completely high-risk route as the last life-saving attempt. I had to document what I am supposed to do. So I gave Tremi and Durva. And, she started to improve in a period of 7 days. Her PS became 1 to 2. No repeated ascitic tapping, jaundice improved, appetite improved, her bilirubin now is 2.85, she is coming to me in OPD, and any guess on AFP level which was there in December, 1,75,000, Dr. Vogel, any wild guess?
I mean, this is what I was saying, right? We always need to consider why do these patients deteriorate.
So yeah, I mean, if I were to go with the guidelines, only palliative care.
Can I request you,
Yeah, it's on, it's the last slide, sir, it's slide.
9:15, and we have
So
still 2
AFP
more
level turned out to be only 31. So she had a fantastic response, and obviously she's due for a second dose of Durva, and she's planned for assessment after 3 cycles because it's the time, that point which I had. And obviously with this, I thank you.
Excellent, very well done. Thank you. So can we move on? And I have the privilege of inviting Dr. Anand Pathak to take the discussion forward on the next case on HCC. Dr. Pathak, can you hear me?
Good evening, sir. As Dr. Pathak is not well, I'll be conducting the further case discussion and moderation of this second case.
Request you to introduce yourself.
Yeah, myself Dr. Amol Dongre. I am a Director of Medical Oncology at Max Super Specialty Hospital, Nagpur.
Thank you so much.
Yeah. So, shall I start with the case, sir?
Please, go ahead.
So, Dr. Vedika is going to present case, and then we'll be following with the discussion.
Hello. So, good evening, everyone. This case, 56-year-old male, he is a diagnosed case of hepatitis B on treatment since 2010, and he presented with chief complaints of jaundice, fatigue, anorexia, and weight loss in January 2022. He was investigated for the same in 2022. USG abdomen pelvis was suggestive of cirrhosis of liver with space occupying lesion, query HCC, and upper GI scopy was suggestive of large esophageal varices, for which he underwent band ligation thrice. And in May 2022, he underwent CECT abdomen pelvis, which was suggestive of cirrhosis of liver with mass lesion in right lobe of liver, query HCC, and his AFP levels were 3000 nanogram per ml. He underwent PET-CT on 4 June 2022, which was suggestive of FDG avid, enhancing mass lesion 3.8 by 3.7 by 4.3 centimeter, involving segment 8 of right lobe of liver, suggestive of neoplastic pathology, query FCC. Liver shows nodular surface with relative hypertrophy of quadrate lobe of liver, suggestive of cirrhotic liver, mild splenomegaly, no active disease elsewhere. So TNF staging of this patient was CT1B, N0M0, and BCLC was early stage A. Childhood score was class B. So this was the liver on PET-CT. So he underwent liver transplantation on 19 July 2022, and donor was his son. Post-transplant, his serum AFP levels were less than 7 nanogram per ml. And the follow-up PET-CT was done on 19th October 2022, which was suggestive of no disease. Post-liver transplant status, no metabolically active lesion in hepatic parenchyma of transplanted liver,
no metabolically active lymph node, no significant ascites, no any significant disease elsewhere. So this was his a transplanted liver. So he again underwent PET-CT in August 2023. There were suspicious lung nodules of centimetric size, no obvious metabolically active lesion in transplanted liver, no evidence of metabolically active disease elsewhere. And his serum AFP levels were less than 7 nanogram per ml. So he continued surveillance, and the PET-CT was done in February 2024, which was suggestive of metabolically active well-defined nodules in upper lobe right lung, which were 12 by 10 mm with discrete other nodules 7 mm along the middle lobe of right lung, suggesting metastasis, no obvious metabolically active lesion in transplanted liver. And in his serum AFP levels were 9.43 nanogram per ml. So this was the lung lesion, and post-transplant liver was normal. So patient took cabozantinib for 3 months from February to April 2024, and his serum AFP level decreased to 6.44 nanogram per ml, and tablet cabozantinib was stopped, and patient continued surveillance. His serum AFP levels in December 2024 was 87.2 nanogram per ml, and he again underwent PET-CT on 2nd January 2025, which was suggestive of FTGA with nodules in bilateral lung fields, largest measuring 2.1 by 1.7 centimeter, increase in size, number and metabolism compared to previous PET. Now obviously metabolically active lesion in transplanted liver. So a biopsy from lung lesion was done, which was suggestive of metastatic adenocarcinoma, and IHC was suggestive of hepatocellular carcinoma in a known case. So this was his PET.
Well, so thank you, Dr. Vedita, for the case presentation. Now, so can I move on to the panel discussion?
Please,
so
please
we
go
have
ahead.
Dr. Mukesh Ban, Dr. Samir Shirangawar, Dr. Murtaza, and Dr. Sushantikar as my panelists. So as you have seen that this gentleman, 56-year-old with hepatitis B positive for last 10 years, and then had an incidental USG finding of chronic liver disease with SOL. And his CECT did show a space occupying lesion in liver with AFP levels of more than 3000 nanogram per ml. So what will be your approach in such patient, CLD patient, hepatitis B positive on treatment, develop SOL with AFP level of 3000? How will you approach, Dr. Mukesh? Start with you.
See, in our practice, most of the time we come across this scenario where the hepatitis B is positive and then you have SOL, and most of the time we have understood that it's a disease there actually. So if AFP more than 300, 400, we don't try to do biopsy or anything. We understand there is a disease, and then accordingly we try to categorize based upon, as sir told about all the 4 factors: patient, liver, tumor, and the treatment factors. We take a call and take a decision based on this, whether the patient comes in BCLC A, B, C, D, or what is the child book, and then take a call further as per the staging plan.
Yeah, so Samir, how you proceed with this case?
So basically, patient was investigated, and there was a suspicion of SCC. So we try to do a radiological investigation, mainly the CT and MRI, and the PET was also done here. So if it is a disease clear-cut based on the triphasic scan, so definitely the decision would be whether it is a disease which can be considered for curative intent therapy or palliative therapy.
Definitely. So his PET scan has been done, and it shows an enhancing mass lesion of 3.5 by 3.7 by 4.3 centimeter involving segment 8 of right lobe of liver, suggestive of neoplastic etiology, mostly SCC, and otherwise liver shows a nodular surface with relative hypertrophy of caudate lobe of liver, suggestive of cirrhotic liver. There's mild splenomegaly, but there's no active disease anywhere in the body. So it's mostly a localized disease with AFP of 3000 and known hepatitis B with CLD.
It is for curative intent therapy.
Absolutely.
The patient would go for surgical resection and transplant, and depending upon the Milan criteria.
Yeah. So if we see the clinical, he's clinically T1B, N0, M0, BCLC, early stage A. So as rightly said, this patient underwent a liver transplant on 19th of July 2022 with his son being a donor, and post-transplant his AFP level dropped to 7 nanogram per ml. So is this a right approach, like this patient underwent a transplant? Yes, Murtuza?
as patient is also being positive for hepatitis B. So if the patient fits in transplant criteria, definitely we should go for the transplant. If suppose patient not is a good candidate for transplant, either because of the PS or the size, then depending on the remaining liver, as it is a cirrhotic liver, it should be more than 50% remaining liver should be functional. This is the our right approach towards the resection. Otherwise, if patient fits, transplant should be curative intent for these such type of patients.
So rightly said, this patient underwent transplant and was doing good. His PET scan done after 3 months post-transplant did show no evidence of disease with a AFP level of less than 7 nanogram per ml. After around DFI of 12 months, this patient showed a PET CT has been done and it showed a single sub-centimeter size liver, right lung nodule. It was suspicious, but there is no evidence of any metabolically active disease anywhere, and the transplant liver is perfectly fine, and serum AFP level is also less than 7 nanogram per ml. So how will you proceed, Mukesh, in such patient with have a transplanted liver with a suspicious lesion in lung, right upper lobe lung, a sub-centimeter size?
We can't hear you.
Therapy. So definitely we should observe this patient being a subcentimetric lung nodule, and we know that we have drugs, but we should be careful when we plan next therapy. If only for a single subcentimetric nodule, I think we can wait and observe.
So are we careful because this patient has a transplanted liver? Professor Vogel, would
Yes.
you comment on this?
Unfortunately, Dr. Vogel had to leave because he
Yes.
has an early morning flight. So we can proceed without his comments here.
Yeah. So Samir, would you observe this patient or will intervene in right away, considering early progression?
If there is only suspicion, I would observe. But it would have been a single clear lung met, which is almost clear cut on the imaging. Or if we biopsy or FNA that lesion, we'll try to do that. If it is single lesion, I may try go with SBRT also in such.
Okay, so in a 7, in a 7
Oligometastatic
sub-centimeter, you would like to go for SBRT, right? You said. So this patient has been observed, and after around again 6 months, PET CT showed progression. Definitely this time AFP level is 9.43 nanogram per ml, and a PET scan shows a well-defined nodule of 12 by 10 mm with SU of 3.9 in upper lobe right lung and with discrete other nodule of 7 mm along the middle right lobe lung, which is suspicious of metastasis. So yes, Murtuza, how will you proceed now with this patient having rising AFP level, 2 lung nodules, initial subcentimeter now become 12 by 17 and 7 mm in 2 different pools?
If radiologically it is confirmed or this metastasis, then I think still we can target these 2 lesions, either SBRT or lung-directed therapy, if it is possible. If it is not possible or any other difficulties, then I will with the systemic.
Yes, Sushant, what's your take on this?
The SBRT option is fair, and definitely AFP like also right, and the previous scans are that the lesion, so definitely so proper SBRT.
Yeah, because otherwise the PET didn't show any other active disease, even the transplant liver is normal. So this patient has been, started on cabozantinib for 3 months, and after that, after starting cabozantinib, a repeat AFP level was done, which shows a declining trend. From 9.43 declined to 6.44, and cabozantinib has been stopped. So is it a good approach? I mean, is it a correct approach to stop cabozantinib after 3 months?
So if there is no local therapy was offered, or if the patient had denied the therapy, the cabozantinib
should have continued. So for unknown reason, this patient has been stopped on cabozantinib after 3 months, considering AFP declining and all, and that's why probably after that, almost around 6 months later, his again AFP level rose to 87.3 nanogram per ml, and this time a PET CT showed florid disease progression with FDJ with bilateral lung nodules, largest measuring 2.1 by 1.7 centimeter, and increase in size, number, and metabolism. There is no metabolically active disease lesion noted in transplanted liver, and this time we again went ahead with a biopsy of that liver lung lesion. It shows metastatic adenocarcinoma with glypican 3 positive. And HEPAR1 and TTF1 negative suggestive of STs. So now, what will be your? How will you proceed in this patient? Yes, Mukesh.
So, as the previous talk discussion was there, whether to consider immunotherapy in a post-transplant situation. I don't have experience of it, but as sir was telling, he has used. If can be considered, that is one option, but we have to go see the data more as it comes and take a call. Otherwise, oral targeted therapy, oral therapies are available. We can shift to any of the oral therapy and consider continuing.
So how many of you wanted actually immunotherapy in post-transplant liver?
There are some data also discussed in this also that HPV related and this transplant therapy are not at great success.
See, as already commented by Dr. Vogel, the immunotherapy should come as last, when everything has been exhausted. All the TKIs, even chemotherapy has been exhausted, and it can be biomarker driven. The best way to know whether the liver is going to be rejected or not, do a PDL1 on the transplanted liver, on the normal liver. If the PDL1 expression is high, for sure liver will be rejected. So the use of PDL1 is a good predictive biomarker for rejection of the liver on account of the IO. So please don't use IO in the PDL1 expression.
Absolutely, sir. Rightly said, sir, that transplanted liver, we are, not very comfortable using immuno. So, Murtuza, what will be your choice in this patient now, considering multiple bilateral lung nodule, AFP rising, there's no other active disease, the transplant liver is perfectly normal.
How much the time from since the cabozantinib stopped and this?
So almost, if we see the duration of cabozantinib stoppage, vis-a-vis the progression is 6 months.
So either we can rechallenge the cabozantinib or shift to lenvatinib or any other TKI.
So would like to use TKI first.
Can I request to wrap up in the next couple of minutes, because there is still one more presentation.
Yeah. So I think this is my last question. Like for this patient, where the perfect decision is to start on TKIs and then accordingly move on further. Okay. Thank you, sir.
Thank you so much. That was a very interesting case. In fact, post-transplant, the disease serology and the radiology pointing towards a relapse, and not many options are there.
Yeah.
Thank you so much once again. And we move on. Dr. Chitresh, can you hear me? We pass on the proceedings to you to present the HCC case and moderate that. To be presented by Dr. Arun Raja.
So, good evening. Am I audible?
Very well. Thank you.
So, good evening, all of you. I think Dr. Arun Raja is here with me, who will first present the case, and then we will have a discussion on it. So, I first hand over it to Dr. Arun Raja.
Thank you, sir. Good evening for everyone. I'll display my slides. Displayed and presented. So the 67 male retired Army General had a complaint of abdominal pain and distended abdominal fatigue. So after his wife's death, he was on heavy alcohol use. Now a reformed ex-smoker, so history of hematemesis 2 months ago, performance status is 1. So we did a CT scan of chest, abdomen, pelvis. Phasic revealed that the tumor confined to liver and metastatic disease in lung. The child book status was B, AFP was more than 1000. So the biopsy was obtained and confirmed as a hepatocellular carcinoma. Next slide, please. Next slide.
Sorry, we can't see the
This is the course in
slides.
the hospital. So he had a repeated
Dr. Raja, Dr. Raja,
IV albumin supplemented.
Dr.
He had
Raja.
serum ammonia fluctuations in between high ball was given.
Chitresh, can you hear me? Sorry, Dr. Raja, sorry to interrupt you, but we can't see the slides. Can somebody?
We are working on it. Just 1 minute. Are they visible now?
Not still.
But then somebody has Delhi. Are they visible at some other centers apart from Delhi?
Could other centers respond to that question?
It is visible, sir. It's visible.
Visible. Anyway, Dr.
So
Raj,
I think Delhi team has to.
Dr. Raja, in the interest of time, I request you to proceed, and maybe you will have to, summarize it very quickly and then move on.
Yes.
Please, Dr. Raja, please.
Yes, sir. So he was a childhood B, ex-smoker with heavy alcohol usage. So he has a viral markers screen. It was negative. So in course in the hospital, repeated ascetic tapping done, IV albumin supplemented. He had serum ammonia fluctuation, and supportive care was given. So we discussed in tumor board. So since it's child B, so everybody voted against immunotherapy. So the patient went for for a second opinion. Then he reported after 2 months. This time with 6 KD. Again, the re-evaluation has been done. So this time we again discussed with the tumor board. This time they refused to take a decision, but the family wants best of the best. So this time family argued with me, why not immunotherapy? So I planned a stride regime with in between successful dialysis. So second Durva completed, so the AFP decreased, patient is doing well. So the learning objective here is, we used the Durva in CKD, that too with child book B. So I hand over to Dr. Chitresh Agarwal, he will take care of the further proceedings.
So just to summarize it very briefly, we are discussing about a case, a 67-year-old elderly gentleman, cirrhotic liver, alcohol as the main etiological factor, child book B, diagnosed with metastatic HCC, biopsy proven, AFP more than 1000, was offered initially systemic therapy, patient did not undergo therapy, went on query some alternative therapy. After a couple of months, he landed up with Dr. Raja with a CKD. CKD was managed, dialysis done, and then after counseling, he was put on this stride regimen. And the latest is that he has taken 2 cycles of the therapy, and the AFP has gone down from 1000 to 400. So this is about the brief, the prescription of the case. So moving on to the questions. So what set of patients, Dr. Raja, do you consider immunotherapy upfront in HCC, metastatic HCC?
So based on the etiology, based on viral and non-viral, most probably child book A and B I considered in practice.
So in your practice, how many child book B patients would actually be, going for immunotherapy combination?
So in routine practice, most of the 75% of the patients are child book B only.
Correct.
So child book A is very rare to encounter in Indian setting.
So this is what I also feel, that though the data is very strong for child book A, but most of the patients who we put these immunotherapy combos, they are mostly child book B. So, CKD with durvalumab, as you mentioned, so what was your experience, what were the complications you experienced, and how challenging it was?
The challenges, we just went back and researched about the data in CKD with durvalumab. So we found out that durvalumab is not excreted by glomerular filtration. So moreover, it's what to say, excretion metabolism is entirely different. So we take a call. So in between the successful dialysis, so we manage with durvalumab. Moreover, the acute nephritis or proteinuria we never encountered in this dialysis.
Okay. So Dr. Mukesh, I'll come to you now. So viral versus non-viral cause, how important is this while you decide your therapies for metastatic HCC?
As we know that viral responds better to the immunotherapy, but as we have the approvals for both viral and non-viral, and we still try benefit in viral also. So I think this is one of the factors, but not the only important factor.
Correct. So I think that it is an important factor in deciding the therapy, and the data also shows the same way. Dr. Ganju, your thoughts on this?
Yeah, I agree. I mean, viral etiology should be a driving factor to emphasize on the use of immunotherapy, but otherwise also, even in a non-viral etiology, I think there is data to suggest that there is a benefit, survival benefit.
So a very interesting question, that concurrent antibiotic usage in immunotherapy, does it compromise the efficacy, and what is the rationale behind it? Dr. Rajit, any thoughts on that?
Theoretically, it was considered that concurrent antibiotic usage will change your gut flora and probably your response to immunotherapy. But with antibiotic use, we only do it when we really find it necessary. And patients who have to receive antibiotics also have a detriment that they are in a physical condition which is less conducive to have a good response. It has been seen with CA lung patients as well. Those who require antibiotics also don't tend to have a good immune response. But there are other factors associated with it as well, not just the fact that their gut flora has changed with use of antibiotics.
So, childhood we have already discussed. So, how do you switch, or do you switch patients from, upfront TKI to immunotherapy in your practice, and what are the consideration factors? Dr. Ganju?
I usually try to give immunotherapy upfront, but if you are out of options, I think that is something that can be done, switching from TKI to immunotherapy. Yeah.
So see, most of the points had already been discussed. I think the most important point that Dr. Raja wanted to put up with this case was that this stride regimen is doable with a patient who has a CKD, and it is possible to use these combinations even with patients after dialysis, on dialysis, and with a CKD background. I think this is all from us. I would request if any expert comments or any other comment from anybody online.
Thank you, Chitresh, and thank you, Dr. Raja, for that interesting case. And I think the complexity of the disease is underscored by the comorbidities which we would encounter on a day-to-day basis. Sachin, I can see you there.
Yes, sir. Good evening.
Yes. Hi, good evening. If you could offer your expert comment.
I was not in Chandigarh. I'm driving, so I was listening to the whole cases. So I think a lot of things have been already discussed, and just to time also, I would just like to say that in this particular case, maybe Dr. Raja was very lucky that his patient has benefited in this situation. And I don't think many of us would venture into treating such a patient with childhood B and with a poor general condition and also CKD. But maybe as a desperate measure, this was done and success was there in this particular case. Let's hope this patient maintains this benefit for a longer duration. So to my mind, we must respect childhood criteria, and only childhood A patients would be, eligible and doing better. At least B7 may be considered, but beyond that, most of the patients would not tolerate treatment, and they are likely to deteriorate if we venture into such things. And other comments are very valid regarding use of immunotherapy in viral etiologies and TKIs in non-viral, that may be slightly more beneficial. So that's what I have to add here.
Thank you so much, Sachin, for your insights. And I think with that, we come to the end of the proceedings. And I have the pleasant task of thanking everyone who joined in physically here, and in absentia to Dr. Vogel, and to all those who were joining from the other centers. and such wonderful presentations, great moderations, and a great learning experience. It's been a marathon session for the last over about 2 hours. I thank the organizers, the sponsors, AstraZeneca, Aureate, and I think Lupin, and one more, Zymil. I'm at loss to pronounce the exact name. And thank you so much once again. And let's close this session here to meet once again some other day. Thank you so much.